My name is Esteban Martinez. I work at the HIV unit of Hospital Clinic, and I have been taking care of HIV-infected patients for the last 20 years. I have been involved in clinical care and research. I have been aware of many changes in the field of HIV medicine. Most of these changes are for good, but still there are some gaps remaining, which I am enthusiastic that they will be improved in the future. Particularly antiretroviral therapy. This is the point that has brought many of these positive changes. And antiretroviral therapy has been able to provide long life to patients' horizon, and not only to the individual patient, but beyond the patient, to their partners, and even to the society in a concept that it's called treatment as prevention. Although antiretroviral therapy has provided these benefits, it has been at the expense of some problems. In the past, these problems were particularly resistance when therapy was not so correctly administered. Also toxicity, and particularly major toxicity that developed in severe way and immediately following the initiation of antiretroviral therapy. This kind of toxicity has changed into a milder toxicity, sometimes indistinguishable from lack of convenience in which patients may have long-term problems regarding aging, regarding getting older. So antiretroviral therapy has been evolving over the years, and nowadays what it used to be many pills a day with immediate adverse effects and with other problems of interactions has turned into 1-2 pills once daily or twice daily, and much more convenient and simpler and much better tolerated. But still, as I said before, there are the problems in the mid or the long term. Some of these agents may be having mild toxicities in the short term, but in the long term, these mild toxicities may be contributors to comorbidities developing more frequently as the patient ages. There is still a need for improving medication, and we can see it certainly in the future. Guidelines have been developing for initiating antiretroviral therapy, but most of the patients are now on years of antiretroviral therapy with sustained undetectable viral load. And for these patients, sometimes the reason of change in therapy is not virological failure, but other reasons due to different problems. We do not have still adequate guidelines to recommend how to change therapy in these patients, and this needs to be developed in the near future. We do have certainly tools to measure how the patient may be doing with therapy, and this has been classically attached to viral load and CD4 cell counts. These have been very good tools in the past, and certainly they continue being so for many patients at present. But for patients who are already with undetectable viral load and have relatively good CD4 cell counts, they cannot discriminate among those patients that may be at a higher risk of developing problems with the control of HIV infection. So we need better tools, maybe an ultrasensitive viral load or a measure of the viral reservoir or something like that, that enables us to discriminate among patients who are already undetectable. And also regarding immunological status, maybe CD4 cell counts is not enough. The CD4-CD8 ratio has been helpful, but still we may be needing to measure other markers of immunological status or immune activation or inflammation to detect problems that go undetected by current tools. And the future for antiretroviral therapy is certainly not to become simpler and better tolerated, but being more potent, being able to think of a reality about eradication. This is something that cannot be foreseen at present, but there are hints that allow us to be enthusiastic of this aim in the future. Thank you very much.